This year during the education session, along with Dr. Jacqueline Barrientos and Dr. Islam, we authored the educational chapter on CLL, and it's been an exciting year to talk about the evolving therapies, not just in CLL for patients that have had prior therapy, but now we're seeing the approval of these agents across the frontline setting, meaning patients are having more options for treatment as their first treatment when those indications are reached. So as of a few weeks ago now, patients broadly will have the option still of traditional or conventional chemoimmunotherapy, but also now two different targeted agents. One, ibrutinib targets BTK, or Bruton's tyrosine kinase, which is important, and the B-cell receptor pathway, and also some other chemotaxis pathways. And then Venetoclax combination, which is targeting BCL2, or the anti-apoptotic pathway, so in promoting patients' disease towards apoptosis or programmed cell death. They're seeing great disease responses, which you're going to hear about more in the oral presentation. So I'd say overall, the more options patients have, the more options we have to counsel them about a tailored treatment approach, meaning there are both disease factors. We know biomarkers of the leukemia, which are important, and historically chemotherapy has not been as effective for patients with high-risk markers, things we test by FISH like deletion 17p or even deletion 11q. IGHV unmutated patients might have gotten through chemotherapy with a response, but we know in long-term follow-up those are not the patients that derive long-term benefit. And then, of course, TP53 and some other mutations. They're the disease-specific factors. For patient-specific factors, given CLL has a median age of diagnosis of 72 and two other comorbidities that are often present on average at the time of diagnosis, there are also many patient-specific factors, whether they have renal dysfunction, what their other cardiovascular comorbidities may be, that allow us to choose amongst the options for what the patient not only will derive a disease benefit, but also be able to tolerate and derive long-term benefit. So I'd say overall, from moving away from traditional chemotherapy, one, we're able to offer therapies that are more effective for a patient, and secondly, from a safety and tolerability, we're able to counsel patients that they have options when they traditionally may not have. And now we're trying to learn perhaps optimally how to sequence those treatment, which patients need to use them in combination. And that'll lead, I think, to an overall change in how we think about what the goals of therapy are for each patient.